want to welcome everyone to the first official SASI meeting and our inaugural meeting. And to my right is Mr. Eisner, and to my left is Dr. Tony Yeung. And in the crowd here we have notable physicians and industry. I am the president of SASI, and I welcome all of you to this inauguration meeting. SASI is an organization that has been in formation now for quite a while in various forms. Its purpose is in fact to bring together folks from different specialty groups that focus on minimally invasive spinal techniques, specifically surgical techniques that have been evolving over several decades actually. To my left is Dr. Anthony Yeung, who is a pioneer and has been and remains so. We are very happy to have him here, and as we go forward, there have been issues that makes this society a necessity. There are individuals, well-meaning physicians that have great training but have acquired their training through laborious traveling overseas, to specialist locations, and have acquired these skills without a usual standardization being in place. The purpose of SASI is to advance minimally invasive spine surgery to include not just traditional but also non-traditional trained physicians that have espoused the techniques, have learned, have become quite experts at what they do. We would like to be in a position to lead the accreditation, training, as well as ongoing introduction of peer review literature into minimally invasive spine surgery. There is no standard established right now. SASI can do that, and SASI will do that. You have committed members of this organization, literally committing their entire career to making sure that the minimally invasive spinal surgical techniques that they have learned and believe in and seen help patients continue to grow. The techniques have evolved over time from the type of techniques that originally learned from even Dr. Tony Yeung, which is intradiscal, to more now where there's involvement of the extraforaminal approaches, to the compression of facets, to stabilization without fusion. All these techniques have evolved over the last near 2 decades. There is no one physician that knows all, but what we do know is industry is extremely interested in the skill sets of minimally invasive spinal surgery, and there are non-traditional surgeons that have these skill sets, and it is to the benefit of all that these skill sets are indeed conveyed in a meaningful platform that can be reproduced in a safe environment. I challenge everyone here to do their best to help grow this society. It does have a place. There is a gap that has to be filled. The society fills this gap. The folks that are involved are highly committed into making sure that it does it the right way. And I challenge everyone here to give the necessary time to make this happen. Thank you.
Kind of discussed with Walter, how are we going to do this to benefit the audience the most? And we're going to make it informal. Walter sort of is the moderator, and he is going to raise some questions, and hopefully I'll answer some of them, and you can interject at any time to question my position, because we all have a little different opinion. So maybe at the end of the session, we're going to come to some kind of consensus.
Thank you, Dr. Yeung. Like he said, we're going to keep it very informal. I'm curious as to, and by the way, I'm Walter Eisner. I'm a writer for Orthopedics This Week, and we've written extensively about, seems like I write a lot of stories about New Jersey in the last year. And so I'm curious, how many of you here are from New Jersey? Okay. New Jersey's been ground zero for what has become an extremely fragmented world of spine, because spine is an unsettled science. And one of the things I'm going to talk about was a fascinating trial that took place last June in Newark, which we wrote extensively about, and I'll get into that a little bit. And I also want to introduce Eric Muehlbauer, who is the executive director of NAS. I think many of you had a chance to meet him this morning. Because this world of fragmented spine, unsettled science is giving ammunition to payers to deny coverage. It's giving ammunition to regulatory bodies to act in ways that some see as a restraint of trade. And so we're in this very disruptive time. In fact, Eric Topol, who's a physician from Harvard, has written a book called The Creative Destruction of Medicine. And we may not realize it, but we are perhaps in the most disruptive period in medical history ever. So you've got business issues that are at stake here. You've got scientific issues that are at stake here. You've got payer issues that are at stake here. And you guys are wandering into this fragmented, disruptive, boiling kettle of unsettled issues. And it's the great historian David McCullough, who some of you may be familiar with, he gave a speech a couple of years ago at the NAS meeting. No PowerPoint slides. He got up and talked, and for a half hour you could hear a pin drop. But McCullough says that there's nothing inevitable about history, that every moment that is the next moment is based on the actions and the character of the people that are in the time making those decisions. And as a journalist and a writer for our publication that's read primarily by orthopedic spine surgeons, those are the stories that our readers find most interesting, because that focuses all these big complex issues into stories about individuals, and that's why I'm here, to see if there's a good story here. Also, Michael Sheffield is here. He's a writer for the Memphis Journal, and I never write a story about anything happening in Memphis till I've gotten online to see what he had to write about it, because he's here and he always gets it right. So again, we're going to keep this very informal. We've written a number of stories about all this disruption, and there's been nobody more disruptive than Dr. Yeung over here in terms of the established surgical community and pushing forward the notion of minimally invasive surgery. The first time I met him, he did something remarkable, and I'll never forget it. And we were walking in Toronto at a NAS meeting. We had just met, and he tells me a story about a butcher. And I thought, wow, here's a surgeon talking about butchers, because that's usually not the kind of correlation you want to make. And he told me the story about the emperor's butcher who never had to sharpen his knife. And it was brilliant that he gave me a metaphor to understand this whole concept of minimally invasive surgery. And the story is that the emperor asked his butcher one day, "How come you never have to sharpen your knife?" And the butcher explained to the emperor that there are three kinds of butchers. And Dr. Yeung, you jump in and correct me if I get off the reservation here. But there are, not such good butchers, medium butchers, and really superstars. And I know in his training is what you want to create. You want to create superstars. You want to create the best professionals. So the emperor asked him about this not sharpening his knife, and he said, well, the bad butchers, they have to sharpen their knives every day because they're hitting bone, they're hitting tendon, they're dulling their blades. The medium ones, they have a better way of getting through, but he says the master knows how to get through the body without having to use that sharp blade to hit things. And that story always resonates with me as I think about minimally invasive surgery. The title of my part of the talk here is Spine on Trial, and that's in reference to this trial that took place in June. And for us, it really gave a specific example to this whole complex, disruptive cauldron of activity going on. The state of New Jersey wanted to take away the license of a physician, Dr. Kaul. For us, Dr. Kaul is not important. Sorry, Dr. Kaul. What's important was this turned into not who he was, but what he was. And the Attorney General said that physicians like him, with the level of training that they have, if they're performing certain procedures, they're deviating from the standards and the norms, and in fact are a danger to the public and should be defrocked. It's not the term they use, but it's the term I like. So there was a trial, and Dr. Kaul's attorney, named Shaw, I forget his first name for a second here, had on the witness stand Dr. Greg Przybylski, who's a neurosurgeon in New Jersey, and at the time was the past or the immediate past president of the North American Spine Society. The blood doesn't get bluer than that. And it was Dr. Przybylski's opinion that Dr. Kaul should lose his license, not because he's a bad doctor and that there were specific incidences where he had harmed patients, but because he was deviating from medical guidelines. Dr. Przybylski said that Dr. Kaul didn't have the training and the background to be able to competently perform fusion surgeries. His attorney, Charles Shaw, then politely and calmly dismantled, in my opinion, the charges that Dr. Przybylski was making as the expert witness for the Attorney General. Using Dr. Przybylski's own words, Shaw got him to admit that spine surgeons are not definitively guided to determine whether a fusion is even appropriate or not. And he further had him admit that they can't find the source of the pain much of the time. If there are no definitive guidelines, if you cannot determine exactly where the source of pain comes from, what are you deviating from? And we're not here to take sides. We're not here to say, what should be done. This was just our observation, and it was hard for me to fathom how you would make that charge. The fact that you, Dr. Przybylski said, the fact that you deviate from the guidelines isn't in and of itself a deviation. It's going to be very hard for Judge Solomon, I think, to reach a conclusion that deviation took place. He also went on to question Dr. Brzbilski about continuing education and credentialing. Dr. Brzbilski admitted that he and NASS train interventionalists knowing full well they intend to perform the procedures. If, as an educator, you're training people to perform certain procedures, you shouldn't be surprised that then they indeed go out and perform them. After the trial, I had a conversation with Dr. Charles Branch, another former president of the North American Spine Society and a former editor of the Spine Journal. I have a lot of respect for Dr. Branch. He also studied journalism in college, so he's always able to give me a good storyline. He said the real question here, and then Dr. Yeung, I want to pull you into this piece of it here. Dr. Branch said that the real question here is, are there interventional fusion techniques that are effective? If so, what are they, and for which indications, and are the interventional pain physicians the appropriate resource to provide that care? There is not a clear answer to any of those questions, which fuels bigger turf and economic wrangling that's coming to a head in New Jersey. Hence, said Dr. Branch, in New Jersey, because credentialing is local, as it is everywhere, a regional or community effort to establish a credible standard is now polluted with politics, power, economic restraint of trade, and on we go. So you have probably trained more interventional pain physicians to do surgical procedures. I don't even want to call them surgical procedures, to do the procedures that you teach. And the question that Dr. Branch put up, are there interventional fusion techniques that are effective, and for which indications, and are those physicians the appropriate resource to provide that care? How do you think about, how would you talk to Dr. Branch about his statement with that?
Try to keep a simple answer is difficult, but the simple answer is yes. It's evolving to the point where we can do a fusion percutaneously under local anesthesia with the same concepts of fusion that the open surgeons use. Now that is going way beyond what the fusion surgeons are willing to accept, but it can be done, it has been done, and I have done it. Okay, I have done it under local anesthesia and sent the patient home. So the skill set has to be practiced, but fusion is one area that is more than just a technical procedure. We have to know the biology of the spine, we have to know the material used, such as bone grafting. We've shown historically that putting bone even from the iliac crest into this space does not cause a fusion, and so that's where we put in a spacer and we put in screws and we keep adding hardware. So we have to kind of draw the line, because knowing how to do it technically is not doing a fusion. If you're doing a fusion, you have to know the biology, the materials that you use, whether it can be dangerous. And recently, the concept of is BMP safe? And Eugene Carrigy has said, hey, industry had made it was safe, but they're hiding these facts. But in reality, these are small deviations that was not hidden, but it was not magnified because, of course, the company wanted to sell the product. And so I will give my own personal opinion, that's a personal opinion, that I draw the line for appropriate training to spine surgeons who really have to spend a whole year, and now even more than a year, 2 years of fellowship to learn how to do this well. But I can do it technically, but do I understand, the osteoconductivity and the different avenues to gain a fusion? Every thing we try to do when we do a fusion is to get the bone to fuse. Everything else is just supplement. And I happened to start my residency in 1971, where it was considered instability if you had to remove a disc, so you fused. Mayo Clinic did that. But we fused without use of hardware, and it was hard work. But when it became easier by the use of hardware, it became an economic issue because the surgeons got paid for every little screw they put in. And so everybody wanted to jump in to make the most money with the least effort. And that's where kind of it's gone awry. And even then, the surgeons are doing all they can to preserve fusion. But fusion is not a technique. It is it's a science that is still evolving, and it is so complex that no interventionist who knows how to technically put in a screw or put in bone is going to be qualified to do it. So I draw the line there that to set the standard, you have to then go through proper training to obtain a fusion. But having said that, if we as interventionists are successful in treating the source of pain, we're going to eliminate 3/4 of the fusions to only severe deformity and instability, true instability, not mild instability. So the future is going to do what insurance companies, payers all want. They want to eliminate the very expensive fusion procedures that, in the term of qualities, is from $30,000 from Dr. Dennis Crandall to $50,000 to $100,000 according to Dr. Polly. That's still too expensive, and that's where the interventionists come in. We're going to be disruptive to the fusion surgeons, but we're not going to be really qualified to do fusion unless we're trained as fusion surgeons.
Which is one of the reasons you've established the Yeung Endoscopic Center at the University of New Mexico.
I decided that, I have 5 stents in me and I could be gone tomorrow. So I had to make sure that someone's going to carry on my work. And I have 2 professors from the University of New Mexico that decided to come, Dr. Fred Harrington, neurosurgeon, and Dr. Evan Rivers, who's non-surgeon, PM&R. They're both training to do this procedure, but they're doing it in an institution with a boss who is envisioning that this should be a multidisciplinary approach, and we should work together to see who is best qualified to do which part of the procedures to treat our patients in pain. So they came just to monitor what's going on, because I think University of New Mexico hopefully will be the future in establishing the standards of what type of training is needed. They have no economic incentive. They're professors, they're teachers. So I invited them to come, and I'm glad that they did come, because I like to hear from their perspective, because they have begun training with me for the last 3 months, and they actually scrub in.
At some point, we may have a question for you, or the audience may have some questions for you. If anybody has a question as we're going along, just raise your hand. We'll be glad to entertain it. Eric, if I might ask you, this notion of the establishment of standards, credentialing, a new society cropping up. You're not a physician. You're an attorney. Sorry, I don't mean to get everybody mad at you just by saying that. But you've been running the North American as executive director of the North American Spine Society for 10 years?
19 years.
19 years. How has NASS looked at folding in this branch of spine care into its membership, and what efforts are you looking at now on the credentialing side that would bridge this gap between surgeons and interventionalists? And is that even the right way to frame the question?
It's an interesting dilemma, because the field is very fragmented. There's interventional radiologists, anesthesiologists doing pain management, physiatrists, surgeons. There's a lot of people getting involved in this kind of treatment. There's societies all over the place. There's the SMISS, there's the International SMISS, there's International Spine Intervention Society. We have a minimally invasive spine surgery section within the society. So the trick for us is, we're a third generation medical society. The first generation is American Medical Association, American College of Surgeons, big, broad. And then about 100 years ago, you had specialization. American Academy of Orthopedic Surgeons, neurosurgeons, radiology, anesthesiology, they all popped up. So it was all about, what your board certification was. We don't care what your certification is in, as long as you do 50% of your time in spine. Our job is to develop well-rounded spine doctors, not just surgeons. So our strategic strength is in multi-specialty education. So we think that the interventional market, for lack of a better way to put it, is a potential growth area for NASS in the next 5 to 10 years. And we want to bring these experts into the society so that we have a well-rounded approach to teach, our members the ins and outs of all these different procedures. So, if you're an orthopedic surgeon and you're learning from just orthopedic surgeons, everything looks the same. We have a lot of accountability in our education because we've got physical medicine specialists, neurosurgeons, orthopedic surgeons, anesthesiologists, some nurse practitioners, holding each other accountable for what you're trying to teach. So, Dr. Kaul, like you mentioned, he's been to some courses at NASS. And we've had this discussion, should we have prerequisites? Should we have certain level of, you've got to meet this standard in order to take a class? Well, if we're not going to educate them, who is? So we have a duty to try to educate the field. And the problem with some organizations is that they make decisions based on what's best for the organization as a business entity. We pretty much stay focused on what's in it for the member. And as long as I'm at NASS, that's going to be our focus. So I'm here partly because Tony, I talked to him on the phone a couple of weeks ago. He encouraged me to come, and Walter did too. I appreciate what the society is thinking about doing in terms of putting together standards, because that is critical. We've been talking, my membership director is here, we've been talking about whether or not we should develop credentialing, like a board certification in spine. There is a board certification in California, and there's the American Board of Spine Surgery, but it's a very limited group. They're not ABMS certified. So it's not very well received in the field. All neurosurgeons have a lot of spine in their training, so they don't think that they need to have a certificate of added qualification in spine. In the orthopedic surgery field, there is a hand surgery CAQ, it's called. So we're going to explore whether or not we should do that. But then we're just serving a fragment of our members, just the orthopedic surgeons. So it's a dilemma. And do we promote credentialing for spine medicine, spine interventions, spine surgery, or do we develop a whole new term, a spinologist, like a cardiologist? So this is stuff that our board's going to be dealing with in February. We have a strategic planning session, and this is on the radar. And that's a long answer to a short question.
That's very...
But these are complicated issues, so it's and you're right. There's a lot of turbulence. There's a lot of white water. So, and it's important to stay focused on what you can do well. And if this society is going to be good at developing standards that raise the ability to care for patients, then it's got a place in the world.
Thanks, Eric. So you have the executive director of NASS here. You got any questions for him?
Well, I am quite tickled to hear what you have to say, and there's a lot of credibility to everything you've said. I'll just go back even 25 years ago to when even inside NAS itself, there was a huge tough battle, I guess more like 35 years ago, between the neurosurgeons and the orthopedics regards to spine, you will recall. And it got resolved. It got resolved over a period of 5 to 10 years. And I would hope that we can speed up such a resolution. It doesn't have to take that long in this context. I totally agree with some form of standardization, and I would challenge everyone here to understand that the skill sets that we're talking about is acquired currently through multiple layers of training that is not yet available at one location. And you have to be quite dexterous to really understand and use the skill sets. On top of that, I totally agree with Dr. Yeung that it's not just getting the skill sets that's important. It is also appreciating the underlying clinical presentations, the nuances, the non-science part of science of medicine, and applying that to specific clinical situations. And that comes with multiplicity of exposure and trial and error that we think that being able to convey in a more standardized fashion, we can accelerate the training, the non-technical training, and that's the point of the accreditation that we feel will fill the gap between the interventionist and being a true spinologist, if you want to call it that way. So I think you're on the right direction. I think SASI is there with you, and you should take it as an opportunity to incorporate this into your thinking.
There's other groups that doing this on your own, while laudable, is just, it does fragment the field. And so you've got to do it the right way, otherwise it won't be accepted. You got to go through the ABMS. You've got to have the buy-in of all these other groups. Otherwise, they're probably going to have, at least at a very minimum, passive resistance to what you're trying to accomplish. So my suggestion would be to try to work with and within some of those groups if possible, because this, like I said, the American Board of Spine Surgery, I'm not sure how many people they've certified. It might be 1,000, but it's not recognized anywhere. There's no reimbursement that you get extra because you're board certified by this group that a bunch of docs just decided we're going to put together a certification program. So it's got to be done the right way, and you only have one shot to do it right. So that's the only advice I can give you. And NAS can help too if you want some help, because this is an area that we think is important, because ultimately these doctors are all going to be treating patients, and our job is to enhance spine care. It's not to enhance it for orthopedic surgeons, for neurosurgeons, for physiatrists. It's for the patient.
Yes, well, I appreciate it. A number of the members are already members of NAS, ICs, and the various organizations, just so we are correct on the record. So that's already established, yet there remains a gap. So there is a place for SASI in all of these configurations, and we certainly hope the societies will work with it together.
Can I just ask a question about what you'd said before? You were talking about that there's this education and understanding about the biology of fusion. And so just for me to get this clear, so you're saying that physicians that come from backgrounds of interventional pain and interventional radiology do not have that understanding?
That's correct. It's
Yeah.
much more complicated than a procedure for a mechanic to do. Like, you don't want to go to the corner gas station and have a mechanic fix your BMW. It's too complex.
Right.
They have just as much chance to screw it up as, helping.
Yeah.
So I don't think I'm, if I'm a pilot, I can't fly the space shuttle, okay? And I'm an orthopedic surgeon, that doesn't mean I know how to do fusions. And what I'm saying is, we have surgeons that are spending 1 and 2 years of fellowship to learn how to do fusions, which is their major procedure. And so to have someone from the outside come in and say, I can do a fusion, I think that's probably bridging too much of a gap. And I hope in my talk, I will support a lot of things that interventionalists do that will fill the gap, and I think they'll do it better than surgeons. So, but to do that, you have to work together.
Right.
So maybe that line is going to shift, but right now, I'm going to take a stance and I'll explain why, if I need to, why I think I draw the line with fusion, because I supported, for instance, Steve Kuchlich bag for spinology, put in a bag. I tried 6 of those, none of them fused. Okay, but the patient got better, and it looked like they had a fusion, but I know it didn't fuse because I used BMP and it went in the foramen. I took out the BMP, and the bag broke and all the material came out like sand. So if you're using sand to put between bricks, it works as long as it stays in place, but it's not a fusion. So it's a matter of calling a fusion, just like an interventionalist say, I'm a MIS surgeon. Is it deceptive advertising, say you're a surgeon? If you say I'm an interventionalist that will help you stabilize your spine, that's different. Okay, so we're talking about somatics, and we have to work out these type of somatics. You know, everything is economically motivated. You know, Medicare pays for extended care, and there are certified centers, and there are people who just open a room in their house and advertise that we're certified by Medicare to, you know, take care of elderly people, but really, they just open a room in their house. But they're gonna get paid, hopefully, if they were billing Medicare for that service. So I think it comes under, maybe the lawyers can answer that, when does it become false advertising? So I have a problem, and I'll explain why, with labeling yourself as something that your training does not certify you to do. I don't have a problem of you doing it and doing it well, as long as you tell the patient, I know how to do this procedure. I'm not trained as a spine surgeon to fusion because it's very complex. Yeah, Gabe.
We're talking about what the purpose of SASI is. And as Sol Kempson said, that one of the purposes is to standardize. Actually, what I think he meant to say is standardize a training system so that we can learn how to do these procedures. I have trouble when it comes to, we have to standardize medicine. I'm sure everybody does, because we're the type of physicians that if it wasn't for us, this procedure never would have existed, especially you, Tony. If we standardize, you wouldn't develop the technique that you've arrived at today. Now, that's one major important aspect of SASI. Now, I'm going to create a little bit of a wave here, and I understand, and Eric, I appreciate what you're saying about sticking together, which we plan on sticking together with all the societies. But it's coming out right here in this meeting that interventionalists, we don't have too many friends. Tony Yeung, you know, he's helped us out, and I've learned a lot from Tony Yeung. But there's certain things that Tony Yeung does not want us to do. There's a lot of things that NASS doesn't want us to do. You have the American Academy of Pain Medicine, or interventional pain. They don't care about us because surgeons send them work. They don't want to get the surgeons upset. So we need to create a society of minimally invasive spine surgeons that are together, and we form an army to protect ourselves from people who think that we shouldn't be doing certain things. That's one of the purposes of this society. I just want to bring that point out.
Well, Gabe, let me respond. You're very good, you understand what you can do, but you're one of the few non-surgeons that challenged me when I was giving a lecture, and I say, wait a minute, you know, I think I said something like, you're not a surgeon, I'm teaching the course, and you're wanting me to do what you're doing. It is not the right standard. I did some research on SASI and what you think is the standard. That is to do a procedure with local anesthesia, discharge in 12 hours, and have less blood loss. That's like saying, don't make the patient worse and you got a standard. I mean, that's too simple a standard.
That's when you wanted to call the cops on me, right?
Well, no, I said,
Throw me out?
I can set that standard. I said, come to me and I'll do a sham procedure on you and I will hypnotize you to get you better. You know, the standard has to be higher than that. So if I had to comment on your standard, I think that's too simple a standard. It's like I have an MD license, so I can do anything I want. We're way beyond that.
With the proper training,
Well,
we're in
with
America,
proper
Tony.
training-
Tony, we're in America. With the proper training, this is a land of freedom. With the proper training, you should be able to do whatever you want. If the person's not capable of doing it, this is where the societies step in and say, you're not capable of doing this.
Well, let me give you an example. I travel and teach in China. They have traditionalists and they have Western trained. The people in China says, if someone tells me what I have, I'm going to go to a Western trained doctor. If they don't, I'm going to go to both because I want to, try both. And they get along because there's no competition economically. Everybody's paid $20,000 a year by the government. And the government is saying, we're spending all this money for these mega hospitals. We're not doing any good, so they're welcoming private practice. So if you're going to do it and do it well, then I think you may have to guarantee your results, just like going to a car dealer and it's a lemon, they get the money back. Are you willing to do that? I don't think we can do that for everybody at this time because we still don't understand the outcome. If you don't make a patient worse, does that mean you get paid? Do you have to get them better? Do you have to get a fusion to get paid? We're working through all that right now. So what I'm saying is, I hope the standard is high enough that it will allow you to attain that. You make it low enough, everybody qualifies.
No, that's not our goal. Our goal
I know,
is
but
to be
I
very
read your
respected.
standard, it's too low.
You don't know what my standard is, Tony.
Let's be clear that SASI has not yet established a standard. What we have established is the definition, what SASI established as a rule of 5, the definition of minimally invasive spinal surgery as we see it, which encompasses fluoroscopic technique. You're not going to argue with that, are you?
No, but.
Okay, hold it. It also establishes the extent of dissection. Are you going to argue that minimally invasive is encompassing of that?
Well,
no, just a yes or no.
Say that again.
I want to get to a conclusion.
Yeah,
here.
I will tell you.
Okay,
If
just
I'm
a
not
yes
sure,
or-
I'll say no. but
Okay,
let me
that's
say-
fine. Are you going to argue with the fact that minimally invasive encompasses minimal dissection?
Yes.
Correct. Are you going to agree or disagree with the degree of bleeding that one expects from minimally invasive? Yes or no?
Yes.
Are you going to agree or disagree with the fact that it is important to be able to discharge a patient from minimally invasive within a certain period of time rather than in a hospital? Because I know where you practice. Yes or no?
The
Yes
answer
or no?
is yes, but.
Thank you. So those are the various things that we agree on at the minimum starting point. We haven't established a comprehensive approach. We don't care whether it's fusion. We don't care whether it's motion preservation at this point. We're simply trying to get consensus on what is obvious. Yet you go into a courtroom and becomes a debate. We shouldn't be debating what is obvious. That's all I'm saying.
Okay.
Thank you.
You can do a sham procedure and meet your criteria. You can do nothing but meet the criteria. I mean, that's not, and then you want to charge for it. So I'm going to challenge you, if you use that criteria, it's so low that it says, hey, if you hang up a sign and say, I want to sell snake oil, and it's actually water or virgin olive oil, you haven't harmed anybody, but are you doing them any good? I'm saying you got to change your standards to make me more specific. And I have a chance to show what I mean because I've lived through it.
No, we're evolving. We haven't established the full set of standards on every procedure on how to yet.
Well, then-
We're at the conceptual level and having an agreement. And at the conceptual level, we want to make sure this agreement crosses all specialty lines, neurosurgery, orthopedic, and all the various specialties that NAS embraces.
I think we can debate that from the audience, but if you talk to surgeons, they're going to say, you know, why do we get extra training when we can do anything and meet the
This
criteria?
gets to, and it's, like Eric said, you got one shot. Dr. Kaul, you wanted to jump in here.
Actually, to Eric, and his comments about CAS and the other societies. One of the main reasons, one of the reasons for SASI coming into existence was to also provide a legal platform that its doctors and its members could reasonably rely on if they had to enter courtroom of the United States or a medical board. And I think one of the issues that most of us have experienced is lack of support in professional societies when these legal issues present themselves. Sorry. And so while I appreciate your comments about the collaboration and the coming together and finding a common ground clinically, which I think is a good thing, I just wonder how that, or if it would, translate into any legal benefits to the members of SASI, because that's one of the threads that we're going to be communicating strongly, is that if you're a doctor, you're a member of SASI, and you run into these issues, we will be there for you
Some points.
and not leave you hanging dry.
Specific examples.
So, you know, that faces all of us in the medical profession. And, I mean, and personally, I feel that the medical profession, if no doctors testified as experts against other doctors, very few of us would be in courtrooms. But that's not the case. And so with SASI, what we're trying to do at the very least is to provide a panel of experts that will go to bat for its members.
Well, in response, you know, what NAS has done relative to expert witness testimony is put together ethics guidelines. So, you know, one of the reasons that Greg Shabilsky was so straightforward in his responses is because what we do is we police our own and make sure that expert witness testimony is fair testimony. It doesn't become advocate testimony. And so there's a big difference. So you have to be very careful when you put together an organization with that as one of the goals, because you've got to make sure that any of your experts have a very solid basis by which they form their opinions. And spine is very well undefined. We know that. Fusions, you know, there's not enough evidence to support anybody saying that it's the definitive treatment for this, that, or the other thing. So we have to admit where we lack evidence. So I would just caution that, you know, take a look at our website. We're happy to share our ethics program. If you want to have expert witness testimony as a key ingredient in SASI, more power to you. But make sure you do it the right way so that you don't end up getting criticized later. Again, you got one shot to do this right. And we're here as a resource. I'm not interested in, you know, NAS taking over this, that, or the other thing. We're a resource. We're here to facilitate good spine care. And if you're an expert in doing things one way, Tony's an expert in doing it another way. We've got a neurosurgeon, physiatrist, they are experts in doing things another way. Our job is to bring all the best practices forward and try to teach whoever comes to our meeting the best way to treat patients. So,
For the technical folks, we're ready to have Dr. Yeung pull up his PowerPoint slides and go into his presentation. One thing that really struck me as why is there no support? In one of my notes I had, Why do they hate us? And I've spoken to a number of surgeons about what really is behind their problem with you. And I kind of see three things. One is, being a political scientist, I always want to follow the money. And clearly, when you're setting up ambulatory surgical centers and you're taking business away, the restraint of trade, that's clearly there. Secondly, there are some surgeons who, honest to God, believe that should something go wrong when you're doing procedures and an open procedure is required, that you may not have the training for that, and you should have, for lack of a better word, a lifeguard with you, or in relation to help out with that. So there's patient safety. But I personally believe it's a third thing that Dr. Yeung just sort of touched on here. And I heard it from a surgeon who said, how come they get to call themselves surgeons when I went through all this training? And it got me thinking, having had some experience in politics and what's called economic rent in the regulatory and the public affairs, why is it important to you to call yourself surgeons? You have a specialty that potentially, for payers, for the way the science is going, will gravitate towards you. Why pick a fight over terminology when you could go in a different direction? So I just throw that out as an observation. Steve?
You know, Tony alludes to the fact that it's a matter of semantics. It's just more being practical and unemotional. You know, I've been on the sidelines for a long time as a non-surgeon doing surgery. When I talk to my patients and educate them, informed consent, I clearly let them know that I have not formally trained in surgery, and I would not call myself a classically trained surgeon. However, I am very well trained, done thousands of cases in minimally invasive spine surgery. So I am not a surgeon, but I do surgery. And the fact that I do surgery minimally invasively really doesn't make me a classically trained surgeon, but the fact is I'm a physician who's cross disciplines for the benefit of his patients. There's no formal training. That's what we're all here for, to formalize it and to standardize it. But I am not a surgeon. And when the surgeons get pissed off as far as territory, ego, economics, formality, there's really no room for that in medicine, but the world we live in dictates that they become problematic for any number of reasons. When you get back to why they're problematic, none of it has to do with patient care. It has to do with how things are structured in the politics and economics of medicine, like you talk about. It doesn't make it right. And so as we move forward, this headbutting between surgeons and non-surgeons, I have no problem saying I'm not a surgeon. I am not a surgeon, but I do surgery. And in the surgery I do, I'm very well equipped to do, which most of the classically trained surgeons are not, because they have no formal training, and we're defining the standards as we move along. But there's a tremendous amount of time we spend bogged down with this stuff that serves no one. And the way is, how do we navigate through that field effectively? Because better physicians grow in their practice. People are interested in taking care of patients, learn new information, techniques, knowledge, and surgeries to help their patients. That's why we're physicians. There's a tremendous distraction with what goes on between organizations and surgeons, non-surgeons. We've got nurses now doing interventional pain management, Medicare approved. No, they have no formal training. They are practicing medicine. But yet we have a problem with other subspecialties crossing disciplines for all the wrong reasons. And it creates a barrier. And in Europe and in the Far East, it's not as bad because they don't have the same economic systems and the same politics going on. So you're not under a microscope all the time.
Thank you. Okay, we've got about a half hour left in this segment, so I think we better get to your slides. Are we ready to pull those up?
Sure. Everything is economically motivated. That's why Escape Communist China. And Communist China has decided that capitalism is good, and so they have a dual system. We may have to have a dual system.